And this is a session on inclusion body myositis. I think what I'm going to do is, it's all going to be question and answers. I don't have a presentation, but I think the questions will be interesting.
We're going next door.
Everyone will learn from that. We do have Helene Alexanderson here in the room, and I think you just heard from her, but she's really an expert on exercise, and she's going to float between the two rooms. What I'd like to do is just give her a little bit of time at the beginning to see if there are exercise questions and issues that she will address for you, and then I think she's going to go through the other session.
I have been taking therapy, and they started putting the probes on my leg. Do we find those beneficial?
Like electrical stimulation. It's very interesting that you bring that up. There are no studies, and I don't have much experience with that, but I know that all the this thing. Are you in the room? He presented and shared last night about the very positive effects of this stimulation. So apparently his physical therapist puts pads on his lower legs and as well on the thigh. Yeah. So when he's walking, she's able to coordinate the stimulation, helping him to lift his toes when he's initiating a step and then going through the whole gait cycle. So he has also walked. Oh, there he is. You should be describing this instead. But potentially there could be positive effects of that. Have you continued?
Well, therapy ends when the educator says goodbye. But for the time that I did have the therapy, it seemed like it did help someone.
Well, we were planning on doing this study too, so hopefully we can say something more, come back with evidence.
Yeah, have you had experience with vascular occlusion and as how that might help those with muscle degeneration?
I don't have any personal experience, although there is this case report that I mentioned. It was done in Brazil with positive effects on muscle function in IBM and also muscle growth. And to my knowledge, there is a randomized controlled trial ongoing in Denmark looking into the effects of exercise with vascular occlusion. And I think maybe next year they will have some results from that. So that might be a way.
Yeah. How do you feel about aqua therapy as opposed to other exercise programs?
I think that aquatherapy can be a very good way to exercise. You can have the whole range from moving very slowly in the pool, just giving you a range of motion and exercise and just the well-being and being able to move and do whatever you. I mean, it's much easier to move in water. We don't have the gravity working against us. And you can get a real intensive cardiovascular exercise if you're really working much faster. And you can use paddles that increases the resistance. So you can also exercise against the resistance, may potentially improving your endurance and strength. So that could be a good alternative to land-based exercise.
Can you tell me how to determine how much is too much in terms of exercise? I want to maintain my muscle strength so that Dr. Greenberg's magic elixir can kick in and have something to work with. And no one can tell me how much is too much. At what point do you begin to damage the muscle, or at what point do you determine I need to stop exercising?
That's a very good question. I don't know where the point is for an overexertion. I think it's individual for all of you, where your point of working or out too hard is, actually. I'm working along with a board scale. It goes from 0 to 10. And so when I initiate an exercise program, I will have you do one leg exercise, for example. And then I ask, okay, how exerting was this for you? So you did 10 repetitions. And then you say, oh, that was 5, which is that strong exertion. That's not the resistance that I would like you to start with. I would like you to be on a 3, which is a moderate exertion. And then, we go through all the muscle groups that we want to exercise. And so I think on a moderate level is a good way to start. But then you need to challenge your muscle. You need to get your muscles a little bit fatigued to get a result. Otherwise, you won't improve your strength. So if you do an exercise program that you have become familiar with and you know that this is working, I would say that I would recommend you to exercise until you say, this is fine, this is a strong exertion. But it's important that you all try to measure your function and keep track on what could I do 3 months ago. Can I do a little bit more now than I could 3 months ago? Then that's very good. And so as long as you feel good about this exercise program, that you can incorporate it in your daily life, and you don't see any worse effects of the exercise, saying that I can walk a shorter distance that I could do 3 months ago. So I would say that is fine.
Do you have any specific comments on yoga as an exercise? I seem to have, it seems to benefit me when I do it, and especially in developing ways to get off the ground when you're down and need to stand up again.
I would say that is excellent. Yoga is kind of demanding for your muscles. I've tried. So you can apply yoga, like very light yoga, and you can also progress what you're doing there. And also, you have to go down on the floor to do yoga. So that's a good way to exercise and find your way of getting up from the floor. So I would recommend it.
I just wanted to make one real brief comment. When I was diagnosed with SIBM very early this year, I went online. One of the first articles I found was an article by Dr. Alexanderson in reference to a home exercise program that showed statistically significant improvement in patients that did exercise. She was kind enough to send me the protocol. I went to our physical therapist. She set the program up. She measured my strength at the beginning, and then it's probably been, say, 6 months, and there's been significant improvement in muscle strength over that period of time by doing this program. And I cannot encourage you enough to follow that program for the benefits that it provides. And I know everyone's different, and I'm in an earlier stage perhaps, but we've seen dramatic improvement, and I can tell that this exercise program really works, and it's something you can do at home, and you can do it at, twice a day, or however you set it up, or your physical therapist. But I do want to thank Dr. Alexanderson for her work. It's been great. I appreciate it.
Thank you very much for sharing. There was this gentleman in the exercise session yesterday, or it was on Thursday afternoon, and he said, I gave him my email address, and he will post it on the website, and together with some of the exercise program, which are already under the website 2014. So there you have this exercise program with specific pictures and how you can adapt this program to in whatever disease course you're having.
I have a question that I have been, my husband is diligent in exercise, and I think it has helped him. But I tell him not, and you can tell me if I'm giving the correct information or incorrect, I tell him not to work the same muscle 2 days in a row. I tell him to alternate. So if he's going to work his arms today, then tomorrow he should give them a rest and work another part of his body. Now, am I correct or incorrect in this?
I won't say that it's incorrect. With this home exercise program that you mentioned, you work all the muscle groups twice a day. But then I guess it's like a shorter amount of time, maybe on a lower intensity. I would say that if you only exercise one muscle group once a week, that would be too little. Because if you exercise once a week,
today,
yeah.
tomorrow you should let that muscle rest and rebuild itself, and tomorrow then it's the lower body.
Yeah, I would say that sounds good as well.
I just have a quick question for Dr. Greenberg. Are you having any test trials of Oxley? Take advantage of
Yeah, I just wanted to finish with the exercise first. Dr. Alexanderson has to go to the next session. So if there are any other exercise questions, you guys first, and I'll come back to yours.
Doctor, I'm still not clear about the frequency of the exercise. It seemed like you said one thing next door and another thing in the initial answer here, and then I think the term was that's okay or that's good. Should we do an exercise, one exercise group today, and then a day off from that exercise group? That's what I've always heard.
I would say it depends on which exercise program you're initiating on. So the home exercise program that we are using in Stockholm now, you go into 16 weeks of exercising twice a day. But we don't recommend you to do that like all year round for the rest of your lives, because then it will lose the effect. So after 16 weeks going into what we call alternating muscle groups, like every other day, seems like what we do. We have also this unpublished data that we've done a small study on whole body vibration exercising. If you do that kind of exercise, it seems like it's enough exercising twice a week. So I would say it depends on what kind of program you're doing. And was that a good answer?
And you have 16 weeks, you do the same thing the next day?
Yes.
So it is every day the same?
Yeah.
For 16 weeks?
Yeah, although we try to progress and increase the number of repetitions or weights that you're using. But I would say it's not possible to do that for a very long time. So you do your 16 weeks and then you can combine aquatherapy with other home exercise, for example, alternating muscle groups, doing something every day, and then you can go into another period of 16 weeks of exercise. So I want to underline that the evidence is small. There are only like 5 studies out there. But we're trying to learn and understand what is best. So I would say you're all individuals. Some of you don't want to exercise at home. Some of you love to exercise at home. Some of you want to exercise in a group. For some of you, a gym setting is better. So you have to go with something that you enjoy to do as well. One more question and then we have to stop.
Thank you, Doctor. My husband has had IBM for 15 years, so we've seen a number of physical therapists over the years, and then recently, all of whom had seen none or one myositis patient. But my question really is, how can you let us help you? The doctors have spoken about their various databases. Can you tap into the information that we have and allow us to fill out, documents for you to keep track of things that would help you in your research to allow you to then help, us and our loved ones?
So, yeah, that is a very good idea. I don't have that. In Sweden, we do have a register where we put in data on muscle function, and recently we also have data on how physically active you are. But there would be something to look into how we can organize that.
Just a comment on that. Jim here has worked with a physical therapist and put a video for IBM specific exercise, and it's on the IBM website. So that might be something to provide to the physical therapist who's had good experience with IBM.
I'll be happy to send whatever programs and information and publications that I can if you contact me, and you can give that to your local PT. Thank you.
Thank you, Dr. So again, I do want to spend most of the time with questions. Maybe I'll take 5 minutes and just say a few things first, sort of general comments, which maybe will address a number of questions. So everybody here is quite familiar with inclusion body myositis and its frustrations. We do not have an effective treatment for the disease. The understanding of the disease has been very poor historically. I'd say over the last 10 years, 10 to 15 years, there's been substantial changes in the understanding of the mechanisms of the disease. And it's been my approach, my belief that the best way to develop effective treatments for this disease is to understand it, to understand what the mechanisms of it is. We may not ever reach an understanding of the initial events that trigger this disease, that set it off. In some ways, it's not as important as just understanding what the mechanisms are that's attacking and destroying your muscles, to find some into this mechanism, some place where we can enter with a drug, with a therapy that disrupts that process that's going on in the muscle. And that's much more important actually than understanding what the cause of IBM is. Just the mechanism of tissue injury is what's really important, because that's what gives us places to come in with drugs against specific targets, molecules that are present that shouldn't be, that are causing damage in the muscle. And that's been my approach, is to try to understand what those molecules are, what the molecular pathology in muscle is of the disease, in order to rationally then find drugs that we can bring in and try in the disease. And I think that's our best approach. The other issue I wanted to comment on is sort of the rigor that I think you're getting from some of the panelists who don't want to commit to certain therapies that people have tried working. And I think this is ingrained in our profession for sure. And I think you want that from us. I don't think you want us writing columns for Star Magazine about Brad Pitt's motorcycle is clearly the best one because Brad Pitt drives that brand. I think you want us to be how we are. And there's a lot of reasons that we are this way, even within myositis. So, for example, the rituximab trial. Rituximab is a potent B-cell depleting agent with a lot of side effects. And it was studied in polymyositis and dermatomyositis in a big NIH trial that Dr. Otis led. And in that trial, there was a placebo group, and all the patients had refractory disease to get into the trial. They failed all other therapies like methotrexate and prednisone, and they entered the trial, and quarter of the patients went into the placebo group, and about 25% of the placebo group improved within 4 weeks of entry into that trial. Those are patients who got sugar water as their treatment, and it was about a 25% response rate. And these are all patients who failed all therapies that had been tried. It was a criteria. So we have to respect this response. It's a placebo response. It's on both ends. It's not just patients feeling better, but it's doctors evaluating them, also having an expectation of improvement and grading them on scales as having improved. Another example is myasthenia gravis, a very similar trial, a drug under investigation called eculizumab was tried in that. Also refractory patients with myasthenia, within 4 weeks, 60% of those patients in the placebo group improved, 60%. So there are very high response rates on both ends of the side from patients and doctors grading this. So we have a lot of respect for that, and ultimately we want an effective treatment that has efficacy that we can count on when we recommend it to people. I think those are the topics I want to cover. So let me turn it over to questions right now and see where we go with that. I have a mic circulating still, otherwise I would repeat the question. Oh, I'm sorry. Well, stay right there. I didn't realize that you had somebody like that.
Hi, Doc.
That you're standing up is a good clue.
And I'm wearing an orange shirt, so. So could you comment on, first of all, I don't want to put the words around this question a little bit, but Pete Frates, I'm from Massachusetts, and Pete Frates, who's a neighbor of mine in Beverly, did a lot with the Ice Bucket Challenge to provide funding to ALS research, which has shadow effect, I think, to IBM. So I was wondering if you could comment on the existing trials that are going on, BYM-338 or whatever that is, and the protein research that they found related to ALS that may have effects on our disease.
Sure, there are two questions. One is clinical trials, and bimagrumab is it's a drug that's being developed by Novartis. It is being developed for muscle atrophy as a potential treatment for all sorts of conditions in which there's much muscle atrophy. I came across that drug a few years ago and thought it might be a good choice for inclusion body myositis, and developed scientific work in my laboratory to test whether the mechanism by which that drug works might be effective in IBM, and the study suggested it might be. So I went to Novartis with this program, and they agreed to try it. We conducted a trial of a single dose of drug, which showed that muscle enlarged in a small number of patients who got the drug and not in the placebo group. And so that was a statistically significant response, and that prompted a large study which is going on right now with 240 patients internationally to try and determine whether a single dose of drug increases muscle size, which is all we've determined so far, or whether repeated dosing increases muscle strength and function. And so that study is still ongoing. It ends in December of this year. The last patient will have completed 1 year of treatment. The first patient will have completed almost 2 years of treatment for that study. And all of that lies in the company's hands right now. So I don't have access to that data. I don't know what it's showing, if it's even been analyzed at this point. But it is wrapping up. And sometime next year, the company will analyze the data and make a decision about whether it shows a benefit or not, and decide whether to continue the program and exactly how to do that. Bimagrumab, BYM-338 was its name before it was given a pharmaceutical name, bimagrumab. The other question I think had to do with protein accumulation. Inclusion body myositis has a long history of observations of proteins accumulating in muscle, starting with a belief that it was akin to Alzheimer's disease in some way, and I think some of that's out there. It's an idea that I completely disagree with, and we spent quite a bit of time showing that there are still a variety of opinions. But there are other proteins that accumulate in muscle, in inclusion body myositis, and mostly they're studied in the field of ALS and a related group of dementias. And these proteins accumulate in nerve cells, and the same proteins also are accumulating in muscle cells in most people with IBM. So there is some relationship between the disease processes. There is some overlap between the muscle and nerve pathology. Exactly what that is uncertain. Whether if drugs do get developed for ALS that target this pathway, it would be very rational to try those drugs in people with inclusion body myositis as well.
I'm Dale Birmingham from Salt Lake City, Utah. We all suffer the loss of muscles and whatever. Could you comment on impel? I find that losing nerves in terms of sensing nerves. They just can't feel as good on my fingers, and my feet just aren't sensing as much. Could you comment on that? Is that kind of in parallel with the atrophy and lack of use? Or?
Yeah, I wouldn't assume that that's a part of the inclusion body myositis. So, it certainly might be, but it'd be a very small minority. And I think almost all experts would be a little reluctant, maybe Alan Pestron would be the exception, a little reluctant to say that loss of sensation in the skin was a part of inclusion body myositis and not something separate. And I don't know exactly what you're describing personally, but as you reach dexterity, you do rely on dexterity and movement to explore your world. So a lot of feedback of sensation does depend on the motor component, the ability to move effectively and have fine movements. And certainly when you lose the movements in your fingertips in that most distal joint, you do lose that capacity to explore the world in a sensory fashion as well. But there's no primary disturbance of sensation that I would be comfortable attributing to inclusion body myositis.
Yes, my name is Bill Doster, and my wife Leslie was diagnosed about a year ago. And the title of this program is Managing IBM. And I hear where people have had it for 15 years, what does managing IBM really mean? The only thing that we've heard so far that may be of some benefit is exercise. And beyond that, we really haven't heard there's no drug for it, there's no solutions to it. So what does managing it mean?
Right, so I didn't name the title. I don't do a lecture called Managing IBM. But management in the medical profession means what to do about it in all of its forms, even if it's not prescribing a drug. So I guess there is a management issue that I haven't addressed at all, and that's the diagnostic issue over IBM and how physicians approach people with suspected IBM in terms of tests to perform and decisions about whether to do a biopsy, for example. I think everyone's sort of been through most of that already, so it's not all that relevant. But there is a blood test that's available for inclusion body myositis that my laboratory developed about a year and a half ago. And Alan Pestron offers this blood test as a commercial service at WashU. And the blood test is fairly specific for inclusion body myositis amongst people with muscle disease. So if your doctor suspects that you have muscle disease, you might have IBM, a reasonable approach is to get the blood test. And if it's positive and all the other features are typical, to not proceed with muscle biopsy, for example. That's a management issue in terms of how we think about managing patients. There were also patients, and I had someone come up to me just after the session who thanked me for developing that blood test because she had two muscle biopsies which were not diagnostic and was still being treated as if she had polymyositis, and then she had the blood test and it came back positive, and was very helpful in terms of getting off of medications that were helping her. So that's a management issue. I think discussions about exercise also qualifies as management. And hearing opinions, there are differing opinions, but most of us do not treat patients with any medications. And that's also a management decision, an unfortunate one, but a true one.
Well, as anyone or any group looking at all of the trials that are now going on or proposed for IBM, there's the follistatin gene therapy trial, Columbus, Ohio, Regeneration drug company has another kind of a trial. I probably got that name wrong, but is anybody looking at, okay, we've got all these different things going on here, how do we bring them together, or is there a way to make sense out of all this for our IBMers?
They don't come together. That's the issue. Not everything, unfortunately, in the world is about togetherness. There's a lot of separateness, too. And people are working on complementary ideas. There are various motivations that drive that, industry motivations around which drugs get developed and which don't. And it's not a perfect world. Instead, it's a fragmented landscape where bimagrumab came into this almost by chance, because I had a conversation with somebody and got an interest in this and worked on that interest. And Regeneron, I think, is maybe the company you're referring to, is starting to develop something. And the follistatin gene therapy was just something that Jerry Mandel thought would be an effective approach. Was trying to develop it. So there is no supervisor. There's nobody who's looking down and coordinating and saying, here are 10 different things which are effective, and we need to try number 1 and number 2 and number 3 and sort of march through this. It's a much more sort of chaotic landscape where it's just up to individual decisions to decide for people to get the momentum to get some program, therapeutic program going. And I have my ideas about this and how I would like to approach it and see it approached, and other people have their ideas. Sure, the questions about competitive landscapes and funding issues, and those issues are extremely critical. IBM is a highly underfunded disease. The only agency that funds it has been TMA. I have a foundation as well that I started called the IBM Foundation, whose sole purpose is not a patient-oriented, meaning it doesn't do all the wonderful things that TMA does, but its sole purpose is to collect money and spend it on research with the aim of developing drugs for the disease. But besides for TMA and my foundation, there's no foundation that's spending money on IBM. The NIH last year spent spent $8 per IBM patient on their budget for research. If you take the budget for IBM at NIH and divide by the number of affected people in the United States, it comes out to $8 per IBM patient. And if you compare that with Duchenne muscular dystrophy, for example, which has a similar number of affected people in the United States, the NIH spent $1,500 per patient. Or ALS, where the NIH spent about $1,200 per patient. And that's not counting that Duchenne muscular dystrophy has a huge foundation base of funds for the disease, as does the ALS Society. So funding is a huge problem. A huge problem has been poor understanding of the disease and attracting people who are committed to work on it long term. And then there are commercial interests as well, which is sort of the third arm in commercial programs. They're afraid to come into IBM mostly because the disease is poorly understood. And there's a lot of misconceptions about it. Well, many of the drugs that industry has been trying for dermatomyositis and polymyositis actually make much more sense to me for inclusion body myositis. But industry sort of has a different view of the immune mechanisms in IBM, and sort of has largely written it off as a sort of obscure disease that who knows what the cause of it is, and we're not going to take the risk of investing $20 million in an early stage small trial. Anyway, a long answer.
What would you say the number of people in the United States who have IBM?
Number of people with IBM, yeah, it's around, the general estimates are around 20,000.
My question is related to management, Marianne. I was diagnosed a year ago, and my neurologist at this point wants to see me on an annual basis. I'd like to be more proactive, and I wonder if I should be going to an academic institution, if I should be seen by someone on that panel. What would you recommend? And I think it probably pertains to many of us.
I mean, you know, I'm a practicing physician. It's my job to see people. I enjoy seeing people. But I'm not sure what I do for people. Right? So I don't know what I really do other than console and keep them away from doing other things, which I know are bad, but I don't have this list of good things to try with people. So I think people come to me for different reasons, and I'm not really, and I let them come as frequently or infrequently as suits their needs. And so I think what should drive you in terms of seeing your physician is to whatever needs you have to discuss about how you're feeling, but not an expectation that if you wait a year, that some new drug will have popped up at 6 months that you haven't heard about. Because as soon as there's an effective drug for this, everybody will know about it. It won't be something that you'll hear from your doctor.
Dr. Greenberg?
Yes.
Going back to the antibody, IgM antibody, it says that if you test positive for it, that dysphagia will come faster, probably. Are there any other things?
Oh, I think that's too premature to understand that. I know that Dr. Mosafar and Dr. Doyle and UC Irvine have a small number of patients where they've tried to understand whether patients who have an antibody in their blood versus those who don't have a different course. I think they think that there's some more aggressive aspect to the patients who have the antibody. I didn't find that. I haven't studied it as carefully as they have, but in my first paper about the antibody, I did look at the relationship between disease severity and antibody positive versus negative, and I didn't find a correlation. So I think it's going to take probably a couple of years before that data is in. I'm not really sure it'll be predictive for individual people. Things might be true for, on average, for a group, but there can be such a wide range that it doesn't help you to predict how everybody within that group will do.
I've been just ask you what the name of the blood test is that you developed to test
It's called NT5C1A. N as in Nancy, T as in Thomas, 5C1A.
C1A, okay. So it's not just at your lab where you take tests. Can anybody go to their doctor and their lab and have the test?
Yeah, I can't actually do the test even though I invented it. I can't do it and provide it as a clinical service because of federal laws. I don't have a laboratory that's certified by the federal government or state government to provide clinical testing. But Alan Hestron at the University of Washington St. Louis does right now, and he's been offering that test. So it's just blood can be drawn by anyone and sent to him. He has a requisition on his website.
My name is Rick Lipstein. I'm from Las Vegas, and I'm a first-timer. I was diagnosed about 5 years ago, and one of the things that I wanted to come to see was the progression. You know, I'm trying to figure out what I'm in for and what kind of time frame I'm looking at as this thing moves on. And of course, I see everyone at various stages. Is there any near rule of thumb as to when I may lose mobility or use of certain muscle groups or whatever?
Yeah, no, it's a great question about the progression, about what to expect at the beginning. And there is just such a wide range. I think there are people in this room who've had a diagnosis for over 10 years who have fairly normal walking, and I think there are people who have a diagnosis for less than 8 years who have severe involvement with their walking. And so there's a wide range, and I wish I understood that and had what we call biomarkers, something we can test in a person to try and determine where they're going to go with this. I think in general, for most people, it tends to be fairly even. I don't know if there are different opinions here, people who feel like it deteriorated suddenly or not, but I think most people have a sense that it's fairly even. And some people sort of know they're moving along faster early on, and some people seem to know they're moving slowly, and I think it sort of stays that way.
Doctor, what about general dietary concerns for the IBM patient who may not have swallowing issues at the moment? Are there some areas of dietary considerations for patients generally?
No, no dietary considerations. Well, I'm going to amend that slightly. I think protein intake, I don't recommend that people do protein supplements, and they're certainly welcome to do that. But I think maintaining sufficient protein intake, that if you are exercising, you do need protein to build muscle. So you do need to have the sort of minimum recommended protein allowance.
Doctor, I'm curious, you mentioned the lack of funding for basic research. What is the appropriate amount of funding for basic raw dollars? What are you looking at, $20, $30 million?
20, $30 million?
Yeah, I mean,
most people in this field are lucky when they get $20,000 or $30,000 to do research.
Well, okay, you're talking about MD at $1,500 a patient per year.
Duchenne muscular dystrophy.
I'm sorry.
The NIH spends $1,500 per person on muscular dystrophy.
What's the grand total of that? Because I don't know how many people have.
Well, there's about 20,000, 30,000 people with Duchenne muscular dystrophy.
$20, $30 million.
$20, $30 million annual budget.
Okay, so how do you lobby the NIH, or how do you beat them about the head and neck? Is there anybody doing that to get the money increased?
I don't know how the political process works. I guess maybe it works with senators, perhaps. I know in the field of muscular dystrophy, there's something called the Wellstone grants, named after a senator. I don't know what the politics of that, or what the patient organizations did to get that, but they got U.S. Congress to force NIH to create a bunch of muscular dystrophy centers around the country, and that created a lot of money.
Also, I'd just like to add to that, there is a larger organization called the National Organization for Rare Diseases, and they're out of Washington.
There is a larger organization called National Organization of Rare Diseases, which is also NORD, and they do a lot of work in Washington for many rare diseases. A lot more expensive to join that organization, I know that, but that might be something to look into. I also have another question, which is how do you interpret the placebo results of the research you were describing?
Well, different ones have different interpretations. So for the rituximab trial, for example, some of it has to do with the nature of what was defined as the outcome measure in the trial. It's how doctors decide whether somebody has a response. And this particular scale that was used to measure a response in that trial, for example, was very susceptible to bias. A particular bias called anchoring, in which doctors can look back at their previous scores. And these are interesting technicalities, but they're quite important when it comes to performing studies and trying to demonstrate benefits. If a doctor's allowed to go back to his notes, for example, on visit 2, and go back to the visit 1 note and say, well, I scored this patient as a 7 last time, a 7 out of 10. What am I going to do today? there's just some sort of feeling, the patient's smiling, and it's earlier in the morning, and the doctor's not asleep yet, hasn't been harassed with 15 phone calls and interruptions by the nurse. He's more likely to say, oh, you know, I want to do better than last time. And that's just the truth. And that's some of the placebo effect is not patients reporting it better, it's doctors assessing them as better in trials.
In managing IBM, I had I'm over here.
There must be something on the patient. I think I know they did see a neurologist.
I was recommended to have physical therapy because I had fallen. And I was falling all this I was recommended because of swallowing, I was having esophageal dilation, stretch the esophagus, 16 milk, and that was followed by swallowing messages with the Eastern, I forgot what it's called, like little tiny pins in it, that the speech therapist was training me, and that was like, so we were talking about managing, that was something.
Yes, I think it's swallowing. I think she was just commenting that people didn't hear some of the procedures that she had to help with the swallowing, esophageal dilation procedure, and then I hadn't heard of TENS, electrical stimulation of the pharyngeal muscles. It sounds like that was helpful.
We're sharing information today, and for especially first-timers, the best book, the best resource that gave me what's gonna happen to you as you go along is now in a book form, Rolling Back. It's written by Mike Schripp, the fellow who did the artwork out in the field. He also has a blog site or a website. I forget the name of it. Mike. It's S-H-I-R-K. And he starts out just like we did. I kind of stumbled, and then you had a cane, and then you had a walker, and then you had... But it gives you a perspective of how fast that process goes, which his is probably average, and he's all the way now to a Hoyer lift. Basically, you can't do anything. But you can get that book as a Kindle book on Amazon. They have some for sale out of the desk. But it really gives you a good perspective of what's ahead. Unless Dr. Greenberg is
Dr. Greenberg, muscle dystrophy patients, usually the physician prescribes them with steroids, also sometimes growth hormone. Why these will not work with IBM patients?
I don't know how a refrigerator works even, so I'm not sure. I know why steroids don't work in IBM. Androgenic steroids, talking about. So androgenic steroids do build muscle. They build everybody's muscle, and they may work in IBM. There has been one study, the study of oxandrolone, which was performed in Boston, and it was a rigorous study, a placebo group, a carefully performed study of oxandrolone and inclusion-body myositis, and it showed a trend towards the benefit that approached and in one measure exceeded our usual cutoff for saying something works. So they may work. They may work and build muscle, and in that study they appear to work on average. Well, oxandrolone, for example, is a Schedule II narcotic. It's controlled by the federal government. There's not long-term established benefit. That particular one came off the market, I think. It was linked to prostate cancer development or something else. I think it's still available on the black market. I think that's why the investigators didn't follow up with a second study of that to try and understand that. So it's a variety of practical reasons.
Dr. Greenberg, could you elaborate on the efficacy or possible efficacy of IVIG in swallowing with IBM patients?
Sure, I mean, there's data, right? So what is the data that we have? And the data for IVIG is short-term data, like 3-month randomized trial and a 6-month trial. One of the trials included prednisone in combination with IVIG, and both of those trials failed in some statistical way to demonstrate a benefit for IVIG. Swallowing was not the main thing that was measured to assess efficacy. It was limb muscle strength. And then there's never been a long-term IVIG therapy study. There's never been a study of 2 years or 5 years of IVIG plus placebo to see whether it slows down the disease course. So there is a big gap in our efficacy data over limb muscle strength. The gap's worse for swallowing because there's never been a study which addressed swallowing specifically for IVIG. There's just this kind of lore which developed, and physicians are quite susceptible to that, and it's a good thing, actually. But it's been around for 20 years or so, the idea that IVIG helps swallowing, and nobody's designed a sort of rigorous study to demonstrate the efficacy over it. And I don't know how that would work out if somebody did. So I apologize, but I just don't know from a data perspective. I have lots of people who thinks it's helped them, but the problem always is there's not 2. People don't divide in half and go the next 10 years on treatment and leave another half which didn't get the treatment to know 10 years later whether it helped or not.
Yes, I think we're all here because we want to be proactive. We're looking for answers and solutions. And in that vein, a friend of mine recommended a low-dose naltrexone as an off-label treatment for autoimmune diseases. Do you have any knowledge of that, whether it might possibly have some success or whether there's any reason not to try it?
No, I've never heard of that approach. It is Narcan, yes.
Do you feel creatine is beneficial?
I don't know anyone who's studied it. There hasn't been a study of creatine. I know bodybuilders use creatine routinely. Competitive bodybuilders do that, and they consider it to be effective for building muscle, at least during certain stages. I believe that there's lots of muscle in people with IBM that can be built just like everybody else's muscle.
I have a question about swallowing. What percentage of IBM patients have swallowing issues? And secondly, is it inevitable that it'll happen to everybody over time with IBM?
The best number is usually around 30% of patients have swallowing difficulties, and it's not inevitable that it will happen to everybody, I think.
I don't know how common this is with anybody else, but first I'm just going to echo what the gentleman said earlier. Touch sensation in my fingers and in my feet is decreased. I think it's from the IBM. My real question, however, is when I asked the question this morning regarding my hereditary IBM, Dr. Tandon indicated that there was some doubt in his mind that I maybe really had IBM. I was diagnosed by a doctor down in Miami, and I thought that this had to be hereditary from my father, even though he was diagnosed with polymyositis, but that was back in the mid-70s when probably the diagnoses weren't as good as they are today. Should I be concerned that I've been misdiagnosed?
I mean, I think it's, I don't want to give you advice as your physician, right? You can talk to your doctor whether you'd be concerned, but I can talk generally to this issue of hereditary inclusion body myopathies, which really shouldn't be called IBM because the M there stands for myopathy, compared to inclusion body myositis, and that's what the M in IBM stands for. And those are very different diseases. So inclusion body myositis affects certain selected muscles like the grip and the quadriceps, while the most common hereditary inclusion body myopathy does not affect those muscles. Grip would be very, very unusual to be affected from the most common inclusion body myopathy.
Very classic IBM.
Right, so classic muscle involvement is almost always inclusion body myositis. And so the presence of an affected relative, particularly a parent, puts you in a sort of tiny minority that's often interesting to researchers like myself. So I at one point had sort of scoured the world looking for parent-child confirmed cases. Well, you got it right here. With a parent and child. And tried to work out genetics of that, as other people have too. And I think what was being referred to by Dr. Mosavar was a study that was done at WashU, in which all of their patients, and they're pretty good, who had been diagnosed with inclusion body myositis, got gene tested, and 2 of them, about 4%, turned out not to have inclusion body myositis, but to have one of these hereditary diseases. And so we're not perfect, and our diagnostic rules are not perfect, and even people that look like they have a typical inclusion body myositis picture to experts in the disease can still turn out to not have inclusion body myositis, but to have a hereditary inclusion body myopathy. And so I can't tell you exactly what you should do. I mean, it could be a consideration. Those are genes that can be tested for. So your doctor could test you for mutations in VCP, that's the most common one, and those are the 2 that got mistaken at WashU for inclusion body myositis.
Question over here. You mentioned that there are some muscles that can be developed. So are there muscles not affected by the IBM that we could focus on to improve function and maybe compensate for the ones that are affected?
Right, I mean, the deltoids, early on at least, are usually not very affected. That's the ability to bring your arms up like this, for example, in contrast to being able to close your hands. So a lot of people disproportionately lose the closing of the hands with more preservation of being able to bring your arms up like that. It doesn't allow you to, this doesn't help you with turning a key. And so I don't have recommendations that you can work out at develop certain muscles and they will compensate for things that you can't do.
Are you taking the core part of the body, or those affected?
I don't generally think of them as being affected, but they're not muscles that we actually test in the office. And so people have personal experiences about building their abdominal strength.
There is a session on hand exercises in here. There's a session on hand exercises in the afternoon.
At a session last night, they talked about the BYM trial and gave the impression that it's going extremely well and it might even be generally available sometime next year. Can we have your view on where that is?
I don't know how it's going. I have patients in the trial, and there are 4 different groups. There's a placebo, and a low dose, a middle, and a high dose. And I'm not sure who's on what, so I can't really tell whether it's working in some people getting drug or working with people at placebo or not. So that really depends on the company. It is my expectation that it'll be next year, sometime maybe in the late winter or early spring, before the company has analyzed the data and is able to comment either publicly or to physicians enrolled in the trials and then talk to their patients about it, about whether it seems to be working or not and whether the trial is going to continue.
At a swallowing session yesterday, Dr. Tandon mentioned awareness as part of management. And it seems to me that it is awareness. If I think about my own swallowing problems, I don't pop anything into my hand anymore, now that I know what I have and so forth. And I don't know that I want to comment on any book on Amazon.com MyositisFocus.org contains requisition to the laboratory test you mentioned. It contains a 5-page interview with you and with Dr. Pastrana. And it contains a very good description of the difference between hereditary IgE myopathy versus sporadic IgE myositis. So if you haven't exhausted the free website of this organization, maybe that's something that would benefit each and every one of us.
Dr. Greenberg, of course, we all want to thank you for everything that you've done for us and our families. Do you know the incidence of IBM worldwide and whether there's any research being done outside the U.S.? Because at least the doctor from Prague had mentioned that they have a European database of thousands and thousands of patients.
There's a variety of incidence figures that have been published from different countries. A lot of the incidence, prevalence issues have to do with ascertainment about the ability to recognize the diagnosis correctly in people. So historically, there's been a lot of reports of inclusion body myositis in the U.S., Canada, and in Europe, and very little in Asia. And I think largely it's just been a failure to recognize it in Asia, and that seems to be changing as the prevalence in Japan, for example, is going up substantially right now. There's still almost no IBM being reported in Korea or in China. But it's starting to change a little bit in China. I just think it has to do with recognizing the disease correctly. In terms of research, there is research going on all over the world, great research. Which ranges from registries and organizing patient data to basic science that's being done in Germany. In the Netherlands in particular, there's a Dutch group which has been very interested in this disease. They also developed assays for this antibody, as well as been instrumental in studying MRI scans in inclusion body myositis and their value. So there's a lot of research that's going on. I still think most of it has been U.S. focused. I think maybe that's not fair to say. But no, there's a lot in England right now. And I don't know those budgets. I don't think it's very much different than here. I think people still struggle substantially with trying to get money to support IBM research wherever they are. Numbers of people. Yeah, I mean, the standard number, for example, in the U.S. is 70 per million. And that comes out of a Rochester, Minnesota cohort study. But there are numbers in Connecticut of 30 per million. There's a number in Istanbul, Turkey of 1 per million. So there's a tremendous range. And there are numbers for different countries. I don't think they're particularly reliable. I think that 70 per million is an underestimate, but that's what gives us about 21,000 people in the U.S. who are affected.
Yeah. My question to the general meeting about IBM being included in myositis really had to do with the fact that, I'll get to the main point, is it seems to me that you are devoting a lot, or all of your energy on the focus of IBM. And you have this foundation. And I guess I could understand why the Myositis Association can, give you the money for that. But I'm wondering about using the pool of members of the organization to be able to donate money to the foundation, and also people here who, as you research different things, if they would like to be part of different things that you're exploring, if that's something that could be done.
I always welcome donations to the IBM Foundation. That website is ibmfoundation.org.
So will you say anything about that in terms of the members of the organization who, I don't know, emailing you in terms of who has IBM as who developed different studies? I mean, you did bring us the blood test, which is a very good thing, as well as play with a role in the larger study.
Well, it's been hard for me to fund my research. I've never gotten a grant from the TNA to do my research. Technically, I had one grant, but I got taken back after 3 months. But I failed in 4 or 5 other applications to secure funding from this organization. So it is a challenge for everybody to get funding. I'm always looking for it. I did start a foundation with a patient with IBM and his wife, who are the other directors, and their names are on the website. It's a non-profit charity. All the money goes towards research in IBM, and particularly drug development, which is my main focus right now, is developing drugs that I expect will be effective for IBM. So, you're welcome.
Just a comment for those of us who have a feeling of numbness in our fingers. When I was a doctor, I would address that with patients by saying, do you have a feeling of numbness or have you actually lost sensation? And the very simple test is either the finger, yeah, I feel that, or the end of a piece of Kleenex, yeah, I do feel that way sometimes. So there's a distinction between loss of sensation versus feeling of numbness. The other question I wanted to ask is, those of us who have had diagnosis before your blood test, is there any benefit now to going back to get the blood test after the fact?
I don't think so. Unless it's a research environment, and certain people, like we talked about, Dr. Mosafar, Dr. Goyal, we're trying to understand in a research approach whether having the antibody present in the blood versus not predicts course, progressiveness of the disease.
A question and a comment. My skin seems to be like paper now, and obviously my skin is cold when I close that. And that's probably due to the lack of muscles pushing blood to the extremities. But like if you touch my ear now, I could have frostbite. I know I don't, but and the other thing is, listening to the funding issue, maybe we should all just put on our computers a letter to all our congressmen and senators and bug the hell out of them. I mean, they're very good at they test the Obamacare. Whether you think it's good or bad, that's irrelevant. But they got themselves off of it. And I don't know any job in the world that you get a term for 1 year, one time, and you have a pension for life and insurance for life. They don't live by the same rules we do. So we should just beat the hell out of them and send as many letters as we can.
I'd be glad to help arm all of you who want to do that with a slide I have looking at funding, NIH funding rates for comparable neuromuscular diseases with similar prevalences in the United States. I'll put it on my website. I don't know if TNA. I don't know if TNA has such a letter.
Dr. Greenberg, I have a question. Do you have any experience with Eastern medicine and acupuncture as a treatment for IBM?
I don't. Maybe some people in the room have experience with that. Anybody try acupuncture, other Eastern medicine? Augie, of course.
What I can say about acupuncture is that I started with acupuncture right from the very beginning, from my diagnosis, and I can't say that it has improved improved my situation at all. However, one of the things that I've found is that my balance has maintained pretty well. I'm 8 years into the disease right now from diagnosis, and so my balance is still doing pretty well. But the one benefit that was explained to me by my acupuncturist is that for every muscle in the body, there's associated nerves, and acupuncture helps improve the connection, the communication between the muscle and the nerves. And so for that reason, I continue to do it. But it's certainly, I still can't look at the way I'm holding the mic, so.
I asked the doctor before about the stimulation. Could I ask Dr. Roby about this? I understand you've had the muscle stimulation in therapy. Has it benefited you?
I'm sorry, Doc.
You're doing better with therapy than I am.
And for those, I think a lot of people here I had a session last night talking about this new therapy I'm getting with electrical stimulation. It's actually functional electrical stimulation. And I'd say the proof is in the pudding. I had a gentleman come up to me on the first day of the conference, and he actually grabbed my name badge and looked at it, and he says, "I thought that was you." He says, "But I did not recognize you." He says, "You are walking so much better than you were at last year's conference." The bottom line is that, yes, it has helped me a great deal. The last 2 years at the conference, I was using a cane, and I'm not using a cane this year. I was last year, or the last several years, I was using an AFO on my left leg for foot drop, and I haven't worn it yet this year. So it has helped me a great deal. Now, this is me, one person, and this is what it's done for me. I can't say that this can be replicated with anyone else, but hopefully Dr. Alexanderson is going to go back to Sweden and put together a small study to see if she can replicate these same results. For me, yes, it has definitely made a help. And if my wife was in here, she could have testified. She could testify to that it has helped with my walking on flat surfaces and also up inclines and upstairs. I am still going through the treatment, and it's being done at a university in North Georgia with a neurological physical therapist. And so this is something that I'm just kind of trying on my own.
Wonder if we've ever invited a representative from NIH to attend our conference and make a presentation or sit on a panel. I think that would be educational both for members as well as perhaps the NIH. I also wonder if the members of the board who are here today might not discuss at the next meeting a concerted campaign to write letters to those who might influence such choices and do that in a systematic way. To my knowledge, we've not really undertaken that to this point. Thank you.
My question relates to myositis patients and cholesterol meds. For example, Lipitor, Crestor. When my husband went on either one of these, he noticed noticeable muscle weakness. When he went off, this weakness returned to what he was prior. Can you give us any insight on this or how to handle this?
Stay off the medications.
Is there an alternative other than diet?
So it's called a styramine. I mean, there's agents which are not statin agents, that do lower cholesterol. Niacin, for example, does that. And your internists should be quite familiar with a range of other choices for lowering cholesterol levels that are not statin agents.
It is a natural thing to happen. It will, cholesterol medicines will lower your muscle ability, is that weaken
They do
muscle?
with some people, absolutely. Not the majority. Again, it's 25, 30 million Americans are on those drugs, and only a fraction of them develop muscle problems. But the ones that do develop muscle problems, often it's related to drug. Exactly what you said. Come off the drug, they get better, go back to the drug, they get worse.
There are some statins.
Anybody else?
I was just going to say there are some statins that are lipid soluble and water soluble. And I was on Crestor, which was one that is supposedly not as bad as the lipids were. Although when I came off the lipids, it didn't seem like it helped my muscles. And now I'm on Crestor because I really have a very high, cholesterol. I'm in the 300s without drugs. Yeah, that family history too.
I think it's about time then to wrap it up. Thank you very much for